Qui serait bon, ça, oui. Et là, tu l'as.
Pour le participant, il faut cliquer.
Là.
Là, il y a que nous.
Pourquoi il y a que nous?
Ah.
Ok.
La caméra, elle est juste.
Si je parle, non, c'est le.
Ah, c'est bon, là, tu
ouais. Ouais. Si les deux participants sont là. Ça, je ne vois pas, ça va. Ça nous casse les pieds, calmez-vous, surtout à vous d'ailleurs.
Vous cliquez sur le petit moins, je pense.
Ah là, pour le faire cacher, oui. Et moi, je voudrais voir quand je dois arriver.
Ah, d'accord.
Do we expect another people?
In person, yes.
In person first, yes.
And online. I don't know.
Because it's not just 5 to 3. So, and in good afternoon. And outside, we expect some connections.
You, I think.
You, which means you, three. Okay. Students abroad.
Yeah.
Okay. The people abroad, they know you. Yeah. You know each other. So we can take some minutes to know better each other. I'm not going to introduce myself because I'm waiting for your colleagues. But yourself, you are coming?
There's Pankaj.
Pankaj. Okay. And you, who are you?
Okay, it starts.
You should
start. And we are 2 students from CARE, and I'm doing an internship at the APBs on epigenetics for breast cancer.
Okay. And your background, I'm interested especially by your background to know if you are scientists, yes. Physicians, or
biologists. We are biologists.
You are all biologists.
We are in physiology.
Yes, some say all cellular and physiology. Exactly the same background now. Exactly. But one biology. It's a lady or man? Pankaj?
It's a man.
So, Mr. Pankaj, could you introduce yourself? And then I'm going to do myself in 2 minutes when all the people will be present.
So I just need to give an introduction about me.
Yes, you tell me who you are, what is your background.
Okay. My name is
shortly, not a long CV, just shortly, somewhere.
I'm really sorry I couldn't understand you, but I'm giving my introduction. So my name is Pankaj. I'm from India. I'm currently in CARE program, 2nd year. And I'm doing my thesis in FMI, Basel, on C. elegans with protein ubiquitination and development clocks.
Okay, thank you. We'll wait some minutes. It is not yet 3 p.m. Maybe there will be additional connections. You can close now. You think you are all present? I was supposed to meet you already past week, but there was some mistake somewhere. So I'm Etienne Chatelut. I'm professor of pharmacology, particularly in this health faculty, and particularly in pharmaceutical faculty, where your colleagues are present, where we are present. I teach pharmacokinetics and pharmacology of anti-cancer drugs. And I'm also head of a laboratory at the Institut Universitaire du Cancer, which is the Cancer Center Toulouse, and I'm the head of the team, one of the team of the CRCT, which is a cancer research, CRCT, cancer research, C like Toulouse, center. Center in the beginning. Okay. And I'm in front of you to teach. It's not exactly teaching because I hope we are going to discuss together, but at least to talk with you about the pharmacology of anti-cancer drugs, and particularly to consider the relationship between pharmacokinetics of these drugs and pharmacodynamics. So maybe I can close that.
Yeah.
Not necessarily we see your colleagues. So I'm going to talk about pharmacokinetics, and maybe it will be necessary together to remind what is pharmacokinetics and what are the main pharmacokinetic parameters. I will show you that in connection with the clinical trials, and particularly of the phase 1, which is the first part of the clinical development of a drug. I'm also going to talk about a little bit about methodology. What are the classical approach to analyze pharmacokinetic data, and I'm also going to show you an alternative, which is the population pharmacokinetic approach, which is more and more used in the field of drugs, and particularly of anti-cancer drugs. And as my title suggested, I'm going to talk about the relationship between PK, pharmacokinetics, and PD, pharmacodynamics, but mainly to show the difference between the several anti-cancer drugs. And since this introduction, I make an opposition between the small molecules and the other drugs that are the monoclonal antibodies. I have to do that each time. Yes. The general concept is according to these arrows. When we give a dose of a drug to a patient, there will be some concentration, and particularly some concentration at the level of the blood. It's what we call the pharmacokinetics. Even if the dose is the same, there could be a large variability between patients due itself to the variability of pharmacokinetics. And this variability of pharmacokinetics has an impact on the pharmacodynamic of the drugs. Pharmacodynamics means both the efficacy, the therapeutic effect, but also, unfortunately, sometimes the side effect. And the sense, the direction of the, sorry for my English, if sometimes something is not clear due to the English, tell me, and I will try to tell better. And you could, of course, stop me. And you too, Pankaj, you can stop me if something is not clear at all, and if I'm using some terms new for you. I think it's better to make maybe 50% of my presentation, but to have at the end something clear for you than for me to talk, and at the end I've done everything, but nothing is great. So don't be reluctant to stop me. So the direction is this one. PK has an impact on the pharmacodynamic. And the pharmacodynamic does not have any impact on the pharmacokinetic of the drugs. Is it clear for you? You are surprised by that? You know already that, and it's evident. You know what means pharmacokinetic, pharmacodynamics. You have seen that during your previous. This presentation is also the opportunity to remind you what are the several groups of anti-cancer drugs. For me, there are 5 groups of anti-cancer drugs. You agree with me? You know them? You could propose me what are these 5 groups and try to make to give the examples by respecting the chronology of the drugs. There are some that are pretty old. We know them for about 60 years, maybe more, almost 1 century. And there are some pretty new. So it's a way for me to test you, not to evaluate you, but to understand if it's clear or not for us.
Like
The older, what are the oldest?
different types of chemotherapy or also
Good afternoon. Big groups, not a single period, but a really way to discriminate between the anti-cancer drugs. An anti-cancer drugs, it's a drug we give or the patient take orally to cure the cancer. But for me, it's possible to have 5 groups. Cytotoxic. Good. It's good to start with this group because they are the oldest, the cytotoxic. Maybe, yes, an example, taxane, platinum compounds. You know about these drugs? Okay, the cytotoxic. Then, immunotherapy. I'm not sure if I activate it's going to be immunotherapy because I think it's almost the new word. But you are right, immunotherapy, which is very special. Okay? So there are 3 left.
anti-cytoskeleton drugs, anti-microtubule.
They are part of cytotoxic. For example, the example here, docetaxel, it's and there are antimetabolites, alkylating agents, they are all cytotoxic. You are right, they are not, maybe we should say 6 groups. I'm not going to consider them, but you are right. It's possible to give a drug which is radioactive with a specific with a specificity for some target, and it's a way to kill the tumor cells. But we are not going to consider them.
Monoclonal antibodies.
Monoclonal antibody, you are right, but the proposal of your friend with the immunotherapy, they are not all, but most of them are monoclonal antibodies. And not all the monoclonal antibodies, they are not all immunotherapy. There are some monoclonal antibodies which are part of the targeted therapy. Okay? And among the targeted therapy, there are not only the monoclonal antibody, there are also some small molecules. Okay? So make the difference between the chemistry, monoclonal antibodies, small molecules, and the pharmacological definition, cytotoxic. Cytotoxics, they are small molecules in comparison with monoclonal antibody. So here are the targeted drugs, either small molecules like cabozantinib, or monoclonal antibody like cetuximab. I'm going to take this example several times. Here is the immunotherapy proposed by your colleague. One is missing. Maybe you don't know them very well because they are pretty new. The ADC, antibody drug conjugated. There are several ADC and they are used in clinics now for 2-3 years, and there are more and more every month. We can say that. There are monoclonal antibody directed against a specific target, like targeted drugs, but the difference linked to the monoclonal antibodies, several, never one, at least 4, sometimes up to 5, up to 8, sorry, molecule of cytotoxic. Okay, so it's for me the 5 big groups, and the PK/PD relationship are not the same depending of the group of the drugs. Okay, why is this slide about phase 1? Because I'm going to talk about pharmacokinetics. I'm not going to talk about pharmacokinetics in animals, even if it's something useful to look at the pharmacokinetics of a compound before giving the compound to human. It's important. I'm not going to talk about that. I'm going to talk only about clinical pharmacokinetics in human. And the first opportunity to know about the pharmacokinetics of a new compound, I'm not going to tell new compound during 2 hours. So I'm going to tell again drug, even if it's not a drug. It's still a compound in development, but we expect it will be a drug. And the opportunity to look at to know the pharmacokinetic is the phase 1. Do you have a background in terms of clinical trials, the methodology? What is the difference between phase 1, phase 2, phase 3? I don't know your background, both of you, because you were not late. You were at time, but it was earlier. What is your background?
Pharmacy.
Pharmacy. So of course you that, and you?
Bioengineering.
So maybe it's new for you. So you and all of you again tell me if it's new for you. So phase 1, and particularly the phase 1 called the first in human, which means it will be the first time we give the drug to human. And the objective is to look at the side effect, to determine the maximum tolerated dose. It's the main objective, but there is also some secondary objective. And one of these secondary objectives, they are even all important, and one of them is to determine the pharmacokinetic of the drug in human. Okay? Here is not a slide of pharmacokinetics, it's just to tell you the methodology of this phase 1 that consists most of the time to have 3 patients at a starting dose. If it's green, which means there are no major side effects, it's possible to increase the dose. But since a certain level, there will be some dose-limiting toxicity. It's the patient in red. In this case, we are going to include additional patients to know if it's the maximum tolerated dose or not. Since it was okay for the 3 following patients, the dose was again increased, but at this level, regarding the proportion of patients with dose-limiting toxicity, it's a way to define the maximum tolerated dose. For all of these patients included in this phase 1, there will be blood samples to determine concentration of the drug and then to determine the main pharmacokinetic parameter. Do you know some pharmacokinetic parameter between this person?
Absorption, distribution.
It's not a parameter. It's a pathway. Okay. Absorption, distribution, elimination. So some parameter corresponding to these pathways.
The concentration maximum, the area under the curve.
Yes, there could be some parameter regarding the concentration. And there are some corresponding parameters corresponding to either elimination or distribution. We are going to see the main pharmacokinetic parameters. So first I'm going to talk about cytotoxic. And just again, before pharmacokinetic, I forgotten this slide. It's just to show you the way to increase the dose in phase 1 when we have a cytotoxic to develop. This slide, it's important to know that we don't practice that so much now. Why? Because now we don't develop anymore some cytotoxic. We are still using a lot of cytotoxic. Maybe it's still the drugs more often used for patients in proportion, but we don't develop new ones. We developed immunotherapy, ADC, targeted drugs, but not cytotoxic. But you will see why it's important to know this methodology, even if we don't develop these drugs. You see the level of data by convention. I've given the number 1 to the starting dose. The following level, we multiply by 2 the level 2, and then if this level is well tolerated, we increase, but not by 2. We increase only by 60%. We increase, but less and less, which is logical, because with this cytotoxics, there could be, and there will be some very serious side effects. You know the main toxicity of cytotoxicity? If there is only one toxicity to propose, which one you would propose? What is, in general, the toxicity, which is the dose-limiting toxicity of most of the cytotoxics? Is it diarrhea? Is it fatigue? Is it emitting?
Yes.
There could be that. But what is the main dose-limiting toxicity?
Neutropenia.
Neutropenia. It's a perfect answer. Neutropenia. But whatever the toxicity, they are serious. So it's why we increase, but less and less. Now it's the pharmacokinetics. This slide is a figure and the corresponding table of the main pharmacokinetic parameters obtained during a phase 1. You see it's a phase 1, there are several levels of dose. And for cytotoxic, in terms of concentration, there is not a specific concentration to consider. What is important is all the concentration. It's what we call the area under the curve. In English, we can say the exposure of the patient to the drugs. It's, for example, at this level, it's this area under the curve of concentration versus time. And if the drug is given IV, which is the case for most of the cytotoxic, this AUC is only dependent of one pharmacokinetic parameter. This parameter is very important. It's what we call the clearance. Clearance, it's a parameter which impacts on the AUC. I think in the following slide, you will see the relationship. It's easy. The AUC, it's only the result of the dose over the value of the clearance of the patient. Since AUC is a critical parameter of concentration, the clearance is the most important parameter to consider. If there is a large variability between patients in terms of clearance, it means at the same level of dose, there will be a large variability of exposure. And that is critical. It's the same slide, just a draw to show you what will be the concentration in a specific patient. Here you see the infusion of the drug, you see the exposure. The patient will stay 3 weeks with the drug. And here are the concentration corresponding to the second cycle of chemotherapy. The AUC is a result of this ratio. The clearance for a drug is a result of the renal clearance plus the non-renal clearance, which correspond to hepatic metabolism of the drug. There are some drugs for which there are the two ways of elimination. There are some drugs for which one is more essential than the other. We are not going to consider it. For the drug given orally, the exposure is dependent of the same parameter, the clearance, dependent of the dose, of course, but there is an additional parameter, it's the oral durability. What is the percentage of the dose that will attain the systemic blood circulation, the general circulation? It's not important for cytotoxic since they are given IV, but we have to consider this parameter when the drug is given oral. Here is a real result of a pharmacokinetic study during a phase 1. You see there are several levels of dose. There are here the AUC of each patient. What you observe there is a trend corresponding to this, comment on dit cette droite, this straight,
Yes.
yeah, but it's a straight line. Thank you. So this straight line is a way to see the relationship. But what you observe also, you observe at a specific level of dose. We can take this level, which is a recommended dose for phase 2 of this compound. You see this large difference in terms of exposure that correspond to the inter-individual variability of clearance for this drug. This drug is a cytotoxic. Some word of methodology, how to determine the AUC. For this trial in phase 1, we have the opportunity to make many blood samples to the patient. The patient is hospitalized, is included with the treatment corresponding of a new compound. We don't know what will be the side effects, so the patient is in the hospital. So we have the opportunity to make a blood sample here during the infusion of the drugs, and all this blood sample after that. So to determine the AUC, you don't have to make a long pharmacokinetic study to methodology. You just have, you can apply what we call the trapezoidal method. I'm sure you will be able to determine this area here between these two samples. So we can do that for all the samples, and it's possible to have the overall AUC, which is again the critical pharmacokinetic parameter in terms of concentration, because the intensity of the side effect, but also the intensity of the therapeutic effect of this drug, the anti-cancer effect, is dependent of this exposure. It's a way, it's a rule for, it's not a rule, it's what we observe for cytotoxic compounds. So it's just the method I present you. But alternatively, we developed population pharmacokinetic approach. Population pharmacokinetic approach, I'm going to tell you several words about that, because if one day you participate to clinical trial, regarding your background and regarding what you are studying, I think you are not supposed to make pharmacokinetics likely. Yes, no, you don't know. But I think since your teacher of care, or the chairs the chairman of CARE tell us, give them some background in clinical trials, etc., you probably will participate, at least some of you, to clinical trial with this methodology called population pharmacokinetic methodology. Again, that consists to analyze concentration versus time after administration of the drug in patients, but rather than consider the individuals one after one, we mixed the concentration of the several patients included in these clinical trials, and we analyze them simultaneously. This classical methodology is open core. Maybe it's possible to make that. This methodology is called two-stage. Why two-stage? The first stage is to make a pharmacokinetic analysis, which means consider the patient of one patient and determine, for example, the IUC. You determine the clearance. And the second step is to make statistics to evaluate what was the main question of the clinical trials. For example, if it was a phase one trial, to be able to consider the relationship between AUC and dose, and to see if there is a linearity between these two variables. That is the two-stage method. Here, we don't consider the patient one after one. We consider all the concentration from all the patients simultaneously. What is the advantage of this method? It's possible to have only few samples per patient. Here, you need many blood samples to determine the IUC by the trapezoidal groups. Here, you could have only one or two samples per patient, but since you have many patients with some pharmacokinetic data, you will be able to analyze this data and to evaluate a specific question. And this method is particularly used to evaluate the relationship between pharmacokinetic and characteristics of the patients. Since for most of the drugs there is a large inter-individual variability, it's important to try to understand what are the factors, what are the characteristics to explain the variability between patients in terms of pharmacokinetics. What is interest to determine the characteristics with an impact on the pharmacokinetics? It's a too long time. I'm talking for 10 minutes. I have to stop to make sure you are still with me. What is important, for example, to see if the patient with a high concentration are older patients than younger patients have a lower concentration at the same dose, for example. Why it's important? Or to see if the patient with the heavy patients have lower concentration than light, if it's possible to say that, teeny patients.
Yes, Christian.
To see
To have several.
to study those parameters, like the weight or the age, could impact the effect of the drug.
And then how we are going to consider that correctly? Yes, indeed. Pharmacokinetics has an impact on pharmacodynamics. Pharmacokinetics could be dependent, for example, of weight. Then, what could be the clinical conclusion, the clinical consideration of this relationship?
People that you weight more than 60 kilograms, you will take the drug because it has some side effects.
The general question, should we adjust the dose according to these characteristics? If the clearance of the drug is proportional to the weight of the patients, it's a rationale to give the dose not at the same level for every patient, but a dose per kilogram. Is it what we are doing to give the dose according to the morphology of the patients? Yes, it's what we are doing for almost 100% of the drugs. Is it brilliant or not? It seems comfortable, it seems logical, but it's not brilliant. Because for most of the cytotoxic, the clearance, you understand what is the clearance, is the parameter corresponding to the capacity of elimination, is not dependent of the body weight. But we are doing that because we are doing that for 50 years. It's good to do that for children. Indeed, there are some chemotherapy given sometime to children of several days or several months, and the same protocol for adolescents. Of course, we adjust according to the weight, and it's good and it's necessary to do that. We do that also for adults. It's a clinical practice, but it's not better than giving the same dose to every patient. Maybe I'm too extreme in my consideration, but the clearance is just a few correlated to the body weight, but whatever. At the same time, I teach you the generality, but also the clinical practice. You know the clinical practice, but also their limits. But coming back to some presentation of methodology, this methodology now, it's used systematically for a new compound, for a new anti-cancer drugs. The firm, the pharmaceutical laboratory, is going to implement a population pharmacokinetic study. What is the advantage? In phase 1, there is no problem to do the classical methodology because, again, the patient is hospitalized. But in phase 2, and particularly in phase 3, these big trials for which many patients, several hundred of patients could be included, so it's performed in several centers. It will be possible to make only 2 or 3 samples for patients included in phase 3. And to evaluate the relationship between pharmacokinetic and the characteristics. Could you tell me, could you imagine why it's good to do pharmacokinetics not only in phase 1, but also in phase 3? I was supposed to give you this lessons. After the lessons, I was supposed to give you last week. But after thinking a little bit before coming, my idea was maybe it's better to start with this more fundamental presentation about pharmacokinetics and pharmacodynamics. But in this case, it will be better for you to have the previous lessons with the presentation of the. Anyway, we save some time to the next presentation, which is scheduled in several weeks, I think. So maybe you don't know very well phase 1, phase 2, and phase 3. You know enough to answer to my answer, so just try it.
Yeah, because in phase 1, we do it with healthy participants. So these participants, they don't have any disease. But with phase 3, we go with a larger population, and these population are diseased. So maybe there might be, it's important to repeat the pharmacokinetics because to check if there's any effect or impact of the disease state on the parameters such as clearance. For example, if the patient has kidney disease or if the patient has liver disease, so these will affect the clearance, the absorbance.
It's a perfect answer. It was very logical. The idea is in phase 3, you include patients who correspond to what will be the patient of this drug if the drug is registered. They are all, not exactly, but roughly the same patients. They are patients, we are talking about anti-cancer drugs, they are patients with a tumor corresponding to the disease we would to treat after registration of the drug. Okay? In phase 1, the patients are very different. Your answer was perfect, but you did something wrong. You tell something wrong.
Yeah.
You tell us about healthy volunteer. You are right for most of the drugs. For the other drugs, not anti-cancer drugs, the phase 1 are performed in healthy volunteers. But for anti-cancer drugs, and particularly for cytotoxic, but also for the new drugs, in phase 1, we don't include healthy volunteer. We include patients volunteer with patients with tumors. But you are right, they are very different, but it will be the content of my following lesson when we will talk about that. They are very different to the patients supposed to be treated lately with these drugs. It's why it's important to perform pharmacokinetics in phase 2 and even in phase 3. Okay. And it's possible thanks to this methodology. Here are some examples of results of population pharmacokinetic analysis of corresponding to cytotoxic, which is a pemetrexed, which is now registered. It's a pretty old publication. I told you already, the cytotoxic now are not developed anymore, so almost 20 years ago. Here you have the relationship between the clearance of this drug, so pharmacokinetic parameter, and the creatinine clearance. You know what is creatinine clearance? No, not at all? It's a parameter to illustrate the renal function of someone. In our body, we have creatinine. We eliminate creatinine, which is a metabolite of muscular activity. We clear our body of creatinine by kidney. So it's a marker of the renal function. It's something new for you? Yes? You never heard about creatinine clearance? It's the first time for you? Yes, for you, because you seems to be the most surprised by the term, but no, I don't know your background. I don't know if you had some presentation about biology, but clinical biology, biochemistry. You know about this parameter? So we should have a value around here. Here, this patient with a lower value are patients with renal insufficiency, impaired renal function. So you see there is a close relationship between the clearance of this drug and the renal function of the patients. And the consequence of that, this drug couldn't be given to patients with impaired renal function. And in the same time, the analyze also ANC is for neutrophil count, the level of neutrophil of the patients after administration of the drug. And the drug is given here, and as your colleague told us, the main toxicity is neutropenia. You see the neutropenia, and the neutropenia depends of the folate status of the patient, because these drugs interfere with the metabolism of the folate. And the patient with a low level of folate have a higher toxicity corresponding to this lower value of neutrophil count than this patient with a good status of folate. And that is a result obtained by the firm corresponding to this drug with some recommendation in terms of dose and the recommendation to give follow-up to the patient to decrease the toxicity. And it has been obtained by population pharmacokinetic analysis. Just an example to illustrate the application of this methodology. I'm not going to develop that. It was our own study we have performed for a compound. I'm not going to develop that. So it was about pharmacokinetic and the impact. Yes, I didn't develop this slide, but it was some slide, somewhat, at least to convince you. A relationship we observed in my team some years ago for a cytotoxic, carboplatin. The AUC of carboplatin in the patient, and here the risk of thrombocytopenia in patients. And you can see several relationships, but for all the, I'm going to develop this, to explain you these several groups, but you can see there is a relationship between the risk of toxicity and the level of AUC. Why there are several curves is because the compound was given in combination with several cytotoxic, and depending of the cytotoxics, the relationship is not the same. But I'm not going to comment that, it's not important. The idea to show you that is to give you some examples with pemetrexed, now with carboplatin, of relationship between exposure and toxicity. I don't think I have with me some example of relationship between AUC and efficacy, but for cytotoxic, there are some relationship. And the proof of that, for every cytotoxic, the idea is to give the higher dose we can give with an acceptable toxicity. We wouldn't decrease the dose because if we decrease the dose, it will be more tolerable, which is good for the patients, but with a lower efficacy. So the idea for toxic is to determine the maximum tolerated dose. And you have seen a slide, an example of a drug. It was vincristine. The dose considering to further develop the compound for the phase 2 was close to the maximum tolerated dose, to have the maximum of efficacy we could have with the drugs. So it was this first part to give you what we observe for cytotoxic. For targeted drugs, and in the first time, we are going to consider only small molecules, like erlotinib. Some of you know erlotinib. What is the target of erlotinib? The target of erlotinib is a protein. It's a receptor, a membrane receptor. It's a EGFR. Probably you know about EGFR. It's the target of this drug. Cabozantinib, it's what we call a dirty tyrosine kinase inhibitor, because cabozantinib is able to have as a target VEGFR, c-KIT, several targets. But this drug is a good drug to treat renal cancer. Erlotinib is mainly used to treat lung cancer, especially in a patient with a lung cancer, no smoking patients. Here, I think it's the developed formula of cabozantinib. But anyway, all of these drugs, most of these drugs are tyrosine kinase inhibitors. They are given not IV but orally. They are taken by the patient usually once a day, according to a continuous schedule. These drugs, they are not cytotoxic. They are mainly cytostatic. And to have enough efficacy on the tumor cells, it's necessary to have a continuous exposure of the patient to the drug. It's why it's given every day. And fortunately, since it's targeted drugs, their side effects are less serious than cytotoxic, so it's possible to give them continuously. For cytotoxic, do you know why we have some what we call 20 days schedule administration? 20 days schedule administration means the drug is given every 3 weeks. You know why we do that for cytotoxic? Then we give the drug every day for targeted compound small molecules. Why is this schedule here?
Yes, because in order to not have like severe neutropenia.
Yes.
We cover the ALC count.
Good answer. It's just due to the toxicity. We have seen in the previous slides the thrombopenia, the neutropenia. It's necessary to stop the administration to have the patients a recovery of neutrophil count, etc. It would be good to have the drug continuously, but it's not acceptable for the patients. These drugs are better tolerated, so it's possible to have a continuous exposure. But there are some side effects. We don't kill patients with a targeted therapy, but we have often some side effects. Unfortunately, every day in the world, there are some patients treated by chemotherapy who die due to the cytotoxic. Not a lot, fortunately, but some. Just to give you some information about the difference in terms of side effects. Again, for these small molecules, there is a relationship of the pharmacokinetics on the pharmacodynamics. Depending on the level of the concentration, sorry. We could talk about IUC, but since the drug is given continuously, we are used to talk about the mean concentration. The pharmacodynamic effect will be dependent of the level of this mean concentration. And this mean concentration is pretty similar to what we call the minimal concentration. The minimal concentration, which is the concentration just before the following administration. And of course, the concentration we should consider are the concentration that we call the steady state. Here you can see the steady state. The steady state, there is a steady state because the level of the concentration will be exactly the same after each administration and higher than after the first administration. I'm going to ask you a fundamental question of pharmacokinetics. Is someone, not you, because maybe you have an idea since you have a study. You are from which country?
Lebanon.
Liban.
Ouais.
With a very good school of pharmaceutical study in Lebanon, I think, and you are the proof of that. So for the other, for whom it's pretty new, I think you are not surprised to see higher concentration after the second administration than after the first one. You are not surprised, since the patients take the second time the drug. Since when there is still some concentration, there is an accumulation. The concentration is higher. We don't have to comment that. But maybe which is less evident, why at the third administration, the increase is lower than the increase between the first one and the second one. And why after some time, the concentration is going to be exactly the same. Of course, the dose taken by the patient is the same. You have an idea of that, the explanation of that? Are you surprised of that? Would you expect something different? No. Okay, so you are not really surprised. So if you are not surprised, that means maybe you could explain to your colleagues more surprised than you.
Maybe saturation of the receptors.
Thank you very much for your answer. Thank you very, very much. I thank you because it's a very bad answer. It's what we call in French a contresens. In English, how you say contresens in English? Bad understanding. But no problem. And again, thank you for that. Why it's a bad answer? You think, as me, it's a bad answer, or you are convinced by your colleague? It's a good answer. What's your own opinion about this proposal? You have my opinion. I told you already, it's a very bad way of thinking about pharmacology of this compound.
Because
It's bad.
It's targeted.
No, it's not because it's targeted therapy. It's bad because it's a small molecules. Okay? And what you just propose, you propose the interaction of the drug with the target. With cytotoxic, there is no specific target, but you can say cytotoxics, they are going to interact with what? With DNA, directly or not directly, but the cytotoxic interact all with DNA. So the interaction of cytotoxic with DNA or of erlotinib with the EGFR is very important, is the explanation of the anti-cancer effect of this compound. It's the pharmacodynamic of these compounds. It's something very important, and probably the thing more important to know about a drug, what is the mechanism of action. But in terms of PK/PD, this pharmacodynamic does not have any impact on the pharmacokinetics of the drug. And here we are talking and we are considering plasma concentration. It's pharmacokinetics. There is no impact. And it's for that, not only for small molecule anti-cancer drugs, it's like that for every drugs, small molecules. It could be a beta blocker in cardiovascular, it could be antidepressive drug. The interaction of beta blocker with the beta receptor, it's important to understand why they decrease the level of arterial pressure, but that doesn't have any impact on the pharmacokinetics of beta blockers. Okay? It's why, first, your answer was not correct. And the second was to use the term saturation. Because, so we forget pharmacodynamics. We understand this steady state does not have any connection with pharmacodynamics of the compound. Okay? If we could be able to give docetaxel repeatedly every day, we are not going to do that because we would kill the patients. But if we would do that, and even there are some cytotoxic in some specific protocols with the cytotoxic every day, there will be a steady state as well. So it's not dependent of the pharmacodynamics. So in pharmacokinetics, sometimes the word saturation needs to be considered, but not often. Even for the drug metabolized by the liver, and also for the drug eliminated by the kidney, for most of the drugs, there is no saturation. The metabolism is not saturation, because the pharmacological concentration are far below the Michaelis-Menten parameter. If you would a very technical answer to consider saturation. You know saturation, the mechanism maintained. I'm sure you have studied that. It's a way to describe the saturation of metabolism. But for most of the drug, even if they are metabolized, we are not in the level of the saturation. So here, it's not a question of saturation. I understand the curve is like the mechanism maintained curve, but again, here it's the time after administration of the, okay? And even it's the opposite. We have a steady state because there is no saturation of the mechanism of elimination of the drug. It means when the concentration increases, la vitesse d'élimination, speed of elimination, the speed of elimination, if someone have a better expression, is going to increase with the concentration. Okay? Because there is no saturation. And it will be so at the beginning, after the first administration, the concentration are pretty low. After the second one, since the concentration are higher, the patient is going to eliminate more during this interval than during this one. And after a certain level, the capacity of elimination is going to be the same than the dose given each day. So when the patient eliminates as much drug as it takes, there is a steady state. Okay. I don't know after 2 hours what you will get from my lesson, but if at least you understand that, it's better, it's something about the concept of steady state after several administration. Okay. So again, the efficacy, even for the small drugs, are dependent of the level of concentration, and the side effects are also dependent of this level. And since there is if there is a large variability between patients, probably there will be a large variability of pharmacodynamics. I have some slides to convince you. But before that, not before that, it's a perfect way to illustrate. Here are the pharmacodynamic evaluation of a new compound. You see, it's a more likely result than the previous one I showed you for cytotoxic. This new compound is an inhibitor of equity. You probably have some lessons about this pathway involved in oncology. All of you are making research in oncology, or maybe not? Yes, because care it's oncology, but it could be also aging. Some are more interested by aging than oncology. No, all of you are M1 or M2? So M2, you are not just getting lessons. You are working in a lab.
Yeah.
So is it oncology lab or aging lab?
Oncology.
Okay, so and your colleague in India as well? You don't know? Don't communicate so much. Okay. Myself, I'm talking about only oncology. You understand that? Is it okay? You are not completely exciting by my lesson, huh? No? No, it's okay? It's fine. It's okay, okay, perfect. I will be sure everything takes some interest. Okay, so phase 1 of a new compound, an AKT inhibitor. And for this, during this phase 1, they looked by making blood samples, but not for pharmacokinetics. Here, it's a pharmacodynamic endpoint. I think they have taken the white blood cells of the patients, several several times after administration of the drug, and they looked at the level of efficacy of the drug to inhibit this AKT at the level of the white blood cells, depending of the dose. And you can see the percentage of decrease from the baseline activities is higher for the highest level in comparison with the lowest dose. So here there is no pharmacokinetics. I will show you some pharmacokinetic results after. It's just a comparison of the efficacy of the compound depending of the dose. Just to tell you, this kind of pharmacodynamic evaluation is something maybe you are doing during your training. And I don't know if you are in connection with clinical trial, but I know some students in care, some of them were sometimes I used to make some experimentation consisting to determine this kind of activity. It's what we are doing in phase 1 of these targeted drugs. We were never doing that for cytotoxic. When we developed cytotoxic, the only pharmacodynamic endpoints we looked at was the toxicity, for example, the neutrophil count, and the efficacy to look at the size of the tumors, but no pharmacodynamic endpoint at the level of the cells like here. It's something we apply for targeted therapy, not to cytotoxic. Is it important to consider the concentration and not only the dose taken by the patients? Before showing you some examples, if we remind what is the mechanism of action of most of the targeted small molecules, most of them are tyrosine kinase inhibitors. Here you have a tyrosine kinase, a receptor with tyrosine kinase activity at the intracellular levels. All these compounds are present in the blood of the patients. Then they diffuse into the cells, in particular in tumor cells. And by competition with what? What is the mechanism of action of this TKI? In French, ITK. You don't know these compounds? You should know. Pharmacist or even biologist, no? You don't. Never told you about imatinib, erlotinib, lapatinib, casdatinib. All these drugs with the suffix inhib. What is the mechanism of action to?
Because dephosphorylation, it will remove the phosphatic group.
Yes, they don't. They blocked the phosphorylation corresponding to these proteins, phosphorylation of other substrates. Okay, but here at the level of the target, they are in competition with what? I think you know about that. They are in competition with ATP. ATP is a cofactor necessary to this receptor to phosphorylate other proteins such as RAS, RAF. You know better than me about this pathway. I hope for you, okay? But these compounds, so they diffuse because they are lipophilic, they diffuse into the cells. They have some affinity for the ATP site of the receptor in competition with the ATP, and they avoid, okay? So could you imagine a relationship between the only concentration we consider in human, it's plasma concentration. What would be perfect would be to have the information at the level of the tumor cells, and more particularly into the cell, but it's not possible. The only concentration available when we do a clinical pharmacokinetic study, it's the blood, and more precisely, the plasma, where is the drug. So could you imagine a relationship between the plasma concentration of this patient and the intensity of the effect? Yes or no? What do you think about that? You expect some relationship or not? In introduction, my first slide was to tell you there is an impact of the pharmacokinetic variability on the variability of the pharmacodynamic. So I hope you should think, yes, we expect a relationship, but I know better than just tell the same thing I told already. Why it's logic there is a relationship between, because the effect is it's a competition with ATP. The competition, you know that depends on the concentration, but the concentration at this level, the concentration inside the cells is itself dependent of the concentration outside. So relationship is expected. Maybe there will be other factors. I'm not, first of all, it could be the conclusion of my talk today. There is no, after 2 hours talking about pharmacokinetics is important, but it's probably not the most important. There are other factors. There are factors of resistance. There could be some mutation of this receptor, making the receptor not sensitive anymore to the drug. But now we are talking about pharmacokinetic as one of the factors. So a factor is expected, and indeed, here it's not a general slide, it's an observation for the first targeted drugs used, imatinib, among the small molecules. Here you have the minimum concentration at steady state. You remember what was the minimum concentration at steady state? This concentration, okay, was not the same for all these nearly 70 patients. Some had small value, some had larger value. It explained in part by the difference of dose. Some of patients, the yellow patients, receive only 400 milligrams per day. The blue ones, more 600. Okay. There are more blue here than here, which is logical. The level of dose has an impact of the concentration. Is there any pharmacokinetic variability for this drug? This drug, since you are thinking about the answer, I told you a little bit more about this drug. Imatinib, like all the TKI, is mainly eliminated by metabolism. It's the regular metabolism for the drug. It's catalyzed by cytochrome P453A4. If you have done some pharmacokinetic, if you got some pharmacokinetic lesson, you had some lesson about this cytochrome, the first one, 3 or 4. In our liver, we have cells, hepatocytes. The hepatocytes are responsible of many metabolites and notably metabolites of drug, thanks to enzyme, and the family of enzymes more involved in metabolism of drugs. It's a big family called cytochrome P450. And in this big family, in fact, there are 3 important families of drugs, and the most expressed enzyme, the 3A4, this enzyme is involved in the metabolism of many drugs, including imatinib. Where is imatinib? So is there a pharmacokinetic variability? It was the main question. Yes, there is. You see, there is a mix of yellow and blue. It's not all the yellow here, all the blue here. There is a mix, and you can see the difference of concentration. There is almost a ratio 10 between the extreme value. Then the dose is not so much different. Okay? Here, this part of the slide is the pharmacokinetic variability. Is this PK variability has an impact of on the efficacy of imatinib. Imatinib could be given for a particular tumor, the GIST, gastrointestinal stomach tumor. It's a tumor located in the stomach, due mainly to a mutation of a receptor c-KIT. And this receptor c-KIT, which is a tyrosine kinase receptor, is inhibited, sorry for my English again, by imatinib. It's why the drug is efficient. And here you have the efficacy. It's the survival, more exactly, the progression-free survival of the patients. How long the patients stay with the disease with no progression. So it's better to be like that than to have a decrease. And here, this group of patients correspond to the patient with the lowest quartile of concentration. And the three subgroups here, not the three, the two, sorry, correspond to this quartile and all the patients with it. So you can see, if you have a low concentration of imatinib, you have a lower efficacy than if you have this concentration. This observation made by the firm, Novartis, who developed imatinib, was a key result to support what we are doing for the drug. We give the same dose to every patient, 400 milligrams per day, and after several days, waiting for the steady state, we check the concentration in almost each patient. We check if the concentration is higher than 1 milligram per liter. If the concentration is lower, the physician, when he gets the result, is going to increase the dose in the patients. It's what we call TDM, therapeutic drug monitoring. Therapeutic drug monitoring means to look at the concentration of a drug in the patients, but not during the development of the drug, during the routine clinical practice of the drug, after the registration. Okay? And this practice is applied more and more for tyrosine kinase inhibitor, and it's systematically or almost systematically applied for patients treated with imatinib. Just to illustrate the practice of TDM, nothing to add. So, more than 1 hour, if we make a short resume of what I presented already, for both cytotoxic and small molecule targeted therapy, there is this kind of relationship, considering mainly AUC for cytotoxic, mainly minimum concentration at steady state for these drugs. And I remind you the two slides, this one with a side effect, thrombocytopenia, and this one we have just commented for imatinib with a progression-free survival. What is the clinical consequence of this observation? I'm not talking any more about TDM, I just make the comment. For cytotoxic, we don't do TDM in routine practice because it's not convenient. Anyway, when the drug has been given, it's too late to adjust the dose. The only thing which is done in clinical practice, we looked at the side effect and mainly at the hematological effect, looking at thrombocyte, neutrophil count, and we adjust the dose, we decrease the dose if the toxicity was too high for a specific patient. And we take care of particular characteristics of the patients that could interfere with the pharmacokinetics. We look at the renal and hepatic function of the patients. We take care of the drug-drug interaction between between drugs to adjust or to avoid some combination. Okay, we passed more than 1 hour talking about small molecules. Now we are going to talk about monoclonal antibody, except if you have at this step some questions. Okay? So, monoclonal antibodies. Again, there are two big groups. The targeted drugs, cetuximab. The target of cetuximab, it's exactly the same as erlotinib. Some slides ago, we have seen erlotinib as an example of small molecules, targeted therapy small molecules. It's a tyrosine kinase inhibitors, which inhibit EGFR, as this monoclonal antibody, except that this monoclonal antibody does not diffuse into the cells. They are too big and not enough lipophilic. They are just able, but it's enough for the drug, to bind to the target, EGFR. And you know what will be the following step after this? Here I'm talking about pharmacodynamic of this monoclonal antibody, how they work. So by the drug, by fixing to the target, it's a way to avoid any fixation of the ligand first. And what is the additional and important consequence of this binding of the drug, the monoclonal antibody to the target? You don't know? There will be an internalization of the complex. EGFR with an antibody is going to be internalized and then degraded by the lysosomes. So it's a way to stop the pathway dependent of EGFR. And we know there are some diseases for which EGFR is involved either by the RAS pathway or the PI3 kinase pathway to either survival and proliferation. It's a part of the oncogenesis. You know about that, of course. And you know some disease for which EGFR is involved. It's not involved in every cancer. You have some examples. So we are going to make a small pause, a small rest, and you are going, after your short presentation, to tell me where you are making your training. Since you are all in the field of oncology, I should know the tips.
So, at the PBS, oui, et en cachant.
Ah oui, tu l'as déjà dit, excuse-moi, PBS, donc tumeur du sein.
Yes, the combination of the protein in both of the RNA polymerase. So
Okay.
the RNA polymerase is citrullinated, and this citrulination can be linked to
Very fundamental work or in connection with a special concern?
Fundamental.
Fundamental, okay.
Yeah.
If there is no GFR in your work, the connection between RNA and GFR. You?
I haven't started yet. Next week, I will go to the CNIO in Madrid, working on the team of Francisco Real, and we're working on the bladder cancer.
Bladder, okay. With GFR and bladder, I don't think so. But there will be some breaks later. ADC in bladder, for example. And you?
Now we are working on normal hematopoiesis, but then the goal is to look at acute lymphoid leukemia.
Where? In the CRCT?
Yes.
Okay. There is no GFR. And you?
I'm also at the CRCT in our public team, and I'm working on glioblastoma.
Okay. No GFR.
No, I'm not working now. I started the president in the USA, and I'm working the aging.
Okay.
I'm also in the CRC and I'm doing
immunotherapy.
Yes.
Immunotherapy. Okay. And you?
I'm working at the CRCO paper, and on enhancing speech perception in elderly. So it's cognitive neuroscience.
Okay. EGFR could be some things in CRCT, but mainly of the lung cancer and colon cancer. Okay. Anyway, we come back to the drugs. And immunotherapy, of course, with all other targets like PD-1, PD-L1, and you will see some example of drug like nivolumab. All of you know what is different between immunotherapy and all the other compounds. You had some loss, not you, of course, you should aware about that, but the other, the idea, the checkpoint inhibitors, I don't have to remind you that. Okay. Coming back to pharmacokinetics. The pharmacokinetic of monoclonal antibody is very different than small molecules. First of all, they are not supposed to go outside the blood circulation. They are too large. For the small molecule, there is no trouble to go outside and to diffuse, but not for monoclonal antibody. Too large. Fortunately, they are able, not a lot, a small proportion of the dose is going to leave the blood circulation. Here you have another endothelial cells, and by several mechanisms, including an affinity for this particular receptor, FcRn. You know about FcRn, what it means? Neonatal receptor of fragment Fc of monoclonal antibodies. Neonatal because it's a way to understand why a newborn is able to get the monoclonal antibodies in the milk of the mother. A monoclonal antibody is not supposed to be absorbed, but a newborn, thanks to this receptor, is able to have a passive immunization during the first days of the life. And this receptor is present everywhere in our organism. It's still called neonates. We are not anymore kids, but we have this receptor. And it's a way for the receptor to diffuse into the cells and then to be released at the tissue levels. It's good because without this way to cross the membrane cells, we couldn't have some anti-cancer drugs with the structure of monoclonal antibody. It's also a way for elimination of the monoclonal antibody. In these endothelial cells, particularly if the monoclonal antibody is not only bond linked to the FcRn, is going to be metabolized, hydrolyzed by the lysosome. It's the main way of elimination of monoclonal antibody. But there is also another way of elimination of monoclonal antibody. You remember, I asked you the second step after binding of the monoclonal antibody to the target, then they will be internalized. So you could imagine the cetuximab binding to EGFR and then to be metabolized in the cells. It could be a tumor cells with an overexpression of EGFR. It could be also normal cells, because our normal cells, some of them, particularly at the skin level, express the EGFR. And it will be a second way of elimination of monoclonal antibody. So for the monoclonal antibodies, there are two ways of elimination. Something not specific at the level of the endothelial cells, and some specific corresponding to the target. And in some way, we could say in this time, for monoclonal antibody, the pharmacodynamic has an impact on the concentration. Not alone, but it participates to the pharmacokinetics. And there is a special words for the monoclonal antibody. It's what we call the TMDD, targeted mediated drug disposition. You remember your answer, lady, some minutes ago? In this time, we could imagine the pharmacodynamic, the interaction with the target has an impact on pharmacokinetics. And in this time, you are right to use the term of saturation because the amount of target we have, the patient has, is not the affinity. So, since a certain level of dose, all the target, if we take again the example of cetuximab, which is a famous and very often used drug in oncology, if all the target, since a certain level of dose, all the target will be saturated, and this phenomenon will be of elimination will be saturated. So we should make the difference between these two ways of elimination. One is saturable, the specific one, and the metabolism at the endothelial cells is not specific, is not saturable. So since that is different in comparison with the small molecules. We forget the pharmacokinetic, we come back to the phase 1 and phase 1 of cetuximab. And this table to illustrate this general description of the side effect of monoclonal antibodies, there are some adverse events, but they are not dependent of the dose. And if we look at the side effect observed during the phase 1 of cetuximab, the main toxicity of cetuximab is the skin toxicity. You have like acne syndromes, which is just due to the fact we have, the patient have EGFR at the level of the skin. It's the main adverse event, and it's possible to see this adverse event whatever the level of dose. And you see some level of dose differing by a ratio 10, 50, 500. Okay? So there are some side effects, but not dependent on the dose. So it's not easy to make the phase 1 of a monoclonal antibody. Not easy, at least it's different than for cytotoxic. For cytotoxic, but also for targeted small molecules, we have just to increase the level of dose, and since a certain level of side effect, we say, okay, we can continue to increase the dose, it's the maximum tolerated dose, and we have just to choose a more tolerated dose for developing the dose in phase 2. With the monoclonal antibodies such as cetuximab, it's difficult because there could be some side effect, but it's possible to see this side effect whatever the level of dose. So how to stop the increase of dose? Here are some pharmacokinetic results of cetuximab in phase 1. Here are the level of dose used by the pharmaceutical company. And here you have the clearance of cetuximab. Usually for a drug, we have an horizontal straight line. The clearance, the capacity of elimination is not dependent of the dose. It's what we call a linear pharmacokinetics. There is a variability. There could be different between the patients, but that doesn't depend of the level of the dose. Okay? But for monoclonal antibody, what we see when we increase the dose, the clearance, again, clearance means capacity of elimination, the capacity of elimination decreases. That is a consequence of the saturation of the specific way of elimination of monoclonal antibody. And since a certain level, we have what we had with the small molecule, an horizontal straight line. At this level, there is the specific way of elimination is saturated, and this tolerance corresponds to the non-specific elimination of monoclonal antibody. So this pharmacokinetic result has been the rationale for the firm to choose the dose for the development and likely for the clinical use of cetuximab. They say at this level, all the targets are saturated. It's not necessary to use larger dose of cetuximab in patients. And it's why they are choosing this level. Okay? So, for monoclonal antibody, I've commented already the direction of this arrow, a pharmacodynamic with an impact on pharmacokinetics. And there is a pending question. Is there, for monoclonal antibody, as for small molecules, an impact of pharmacokinetics on the pharmacodynamic? You think it's an important question? And do you have an idea of the answer? What is your prognostic about the answer? What do you think at this level of my presentation? Of course, in the following slides, there will be the answer, but you will see there will be some discussion. And now, maybe most of the scientists agree on the answer. And I don't tell you if it's yes or no. I'm just asking you your opinion at this level. It's an open discussion. At this level, you should have some reason to think yes, you should have other reason to think no. What I think about your opinion. It seems you don't have any opinion.
Maybe it's a yes, and it might be like a combination of the two parameters that we discussed before. Because here we say that we have two ways of elimination. So it's either specific or non-specific. So we should take into consideration both, like the steady state concentration that we talked about with small molecules, and the area under the curve that we used to talk about with drugs.
It's not exactly the question I asked you. The question is, because you are trying to explain why there is this level of concentration depending of the pathway. My question here is, do we have to take care of the concentration of this monoclonal antibody in terms of pharmacodynamic? I wonder if a larger concentration would have a higher efficacy and higher risk of major side effects. It's a question. Regarding the slide I show you, you should say the dose does not this one, sorry, this one. Looking at the dose and the side effect, you should think, no, it seems the dose does not have any impact. There could be some adverse event, whatever the level of dose. So I don't think the concentration could be critical. In another way, if a drug is efficient, it means the drug does better than nothing, better than a placebo. That means the concentration are more efficient than no concentration. So for every drugs, there should be a kind of relationship between concentration and effect. The question is this relationship necessary to be considered to use the drug? And several groups who do, as my group, some pharmacokinetic pharmacodynamic study, looked at the relationship between, here for cetuximab, they have given the same dose of cetuximab to a group of patients. They divided the patient in two groups according to the median AUC. The AUC was not the same. There is an interpatient pharmacokinetic variability, and they divided the patient between those with high AUC, higher than the median, and those with lower than the median. And they looked at the efficacy. Again, it's a PFS patient. It's a patient with a metastatic disease treated with cetuximab. If the drug is efficient, there is no progression of the tumor. And when the patient has the tumor progressing, the patient is here, there is a decrease of this curve. So it's here there is a better result than here. And you can see here that corresponds to the patient with the higher value of PUC by comparison with the patient with the lower value. So the group, it was in France, in Tours. There were comments some years ago, not so long, it was 8 years ago. The level of cetuximab concentration, considering the AUC, in terms of AUC, when we give a monoclonal antibody, they are given almost or even sometimes exactly as cytotoxic. You see, there are a perfusion every 3 weeks. But the difference, they have a very long half-life. So by giving the drug every 3 weeks, we have in fact something similar to small molecule by oral. We have a continuous exposure. It's a targeted drug, and it's necessary to have a continuous exposure to have efficacy. So for the patient, it seems to be like a cytotoxic, but for you scientists, you understand, in terms of exposure, it's more similar than these molecules. So it's possible to consider the AUC between two administrations, or it's also possible to consider the minimum concentration here. So for cetuximab, the French team observed a relationship between AUC and efficacy it was in head and neck cancer at this level. And a similar observation has been done for nivolumab, which is an immunotherapy, a monoclonal antibody, but a checkpoint inhibitor. This Dutch team, they divided the patient, those with a response. Response means a decrease of the tumor, some efficacy. In blue, patient with a stable disease, no efficacy, but a stable disease, which is better than nothing. And PD, like progressive disease, patient with a tumor growing, which means the drug nivolumab was not efficient in these patients. And what they observed, the concentration of nivolumab were higher in patients with efficacy than those in patients without efficacy of the drug. So this Dutch team makes the same conclusion. It seems there is an impact of the concentration of the monoclonal antibody on the efficacy. And at this moment, almost 10 years ago, it was the beginning to think about doing what we do for small molecules like imatinib, therapeutic drug monitoring. The idea was to check the concentration of cetuximab or nivolumab in patients and to increase the dose to have better efficacy. It's what we're thinking these people. But most of the team, and I think even if the team now doesn't believe that anymore. And the proof, maybe the proof of that corresponds to this study. It was a study done for a checkpoint inhibitor, immunotherapy. It was, what is the name? Yes, pembrolizumab. Pembrolizumab, which is used for treatment of melanoma and also some lung cancer. These investigators, they have given pembrolizumab at 2 levels of dose, 2 or 10 milligrams per kilogram. And as the people for cetuximab, they divided the patient between those with a high value of clearance. The high value of clearance were these patients. High value of clearance means low value of exposure. By opposition with a patient with a low value of clearance that correspond to this curve, corresponding to patient with a low value of AUC. Like for cetuximab, they observe a better efficacy. No, I did the opposite, sorry. This value with low value of clearance and high AUC. Here, high clearance, low AUC. And they observe, as the previous one for cetuximab, better efficacy if the clearance of pembrolizumab is low. But what was very interesting in this study, the curve was exactly or almost the same, whatever the level of dose. And we know the patient with a dose of 10 milligrams has much higher concentration than those with 2. So it was a proof there was not a direct relationship between concentration and efficacy. Because if there would be a direct relationship, there couldn't be a superposition of the curve at the 2 levels of dose. And the explanation of that, we have a correlation between pharmacokinetics, the level of concentration and efficacy, but it's not a direct correlation. And the explanation here, it's that there are some confusing factors. The confusing factors are these characteristics. There are some patients with hypoalbuminemia who have cachexia, poor performance status. Performance status means, in French, état général. Patients with a bad or poor performance status. And all these patients are those with a large tumor burden, which means larger tumor than other patients. You can imagine for a specific disease, for example, melanoma disease, at a metastatic levels, all the patients are not the same. There are some patients with a small metastasis, with a good performance status, a normal level of albuminemia. Then there are some patients with a large tumor, cachexia. Those patients have an increase of degradation of all proteins including albumin. It's why there are, most of them, a low level of albuminemia. And those patients with a low level of albuminemia, cachexia, have also a large value of clearance of monoclonal antibody. Because monoclonal antibodies are also proteins. And the clearance of this patient is higher. And since the clearance is higher, the concentration are higher. But if these patients have a lower efficacy, is not due to the pharmacokinetics, is due to the fact that these characteristics are associated with a lower probability of efficacy of the monoclonal antibodies. So it's just the opportunity for me to tell you, I don't know if you are going to work with monoclonal antibody in this field, but be careful of the correlation. Correlation does not mean a direct correlation, does not mean there is a causality. And in fact, considering the pharmacokinetic variability of monoclonal antibody is important, but does not have significant impact of efficacy. Why? Because the dose of monoclonal antibodies we give to the patients are much higher than the minimal dose necessary to have efficacy. Okay, and I could complete this slide by the fact, especially for immunotherapy, currently there are some, I don't know in English, desescalade study. There are several clinical studies evaluating the ability we have to give the dose at the dose recommended by the field, but not every 3 weeks, but that could be every 6 weeks, something less expensive, more convenient for the patients, but with the same probability of efficacy than the regular schedule. Just to tell you, the dose of monoclonal antibody we are using are not an issue, and the pharmacokinetic is not an issue because the level of dose chosen are much higher than the dose necessary to be efficient. Unfortunately, a specific drug is not efficient in every patient. But what we need for these compounds, particularly for immunotherapy, is not to improve our knowledge in pharmacokinetics, is to improve our knowledge of biomarker to recognize patients who are going to respond or not to the drug, to make the good choice. Just to tell you, I believe to pharmacokinetics. It's the minimum after 40 years working in this field. But I believe to pharmacokinetics for small molecules, for monoclonal antibody, probably is not relevant. Okay. So how to choose the right dose of nivolumab? I've taken the example of the drug. During the development of nivolumab, they make some particular evaluations. They look again by getting the lymphocyte of the patients. They determine the percentage of occupancy of the target of nivolumab, PD-1, and they observe at the level of 3 milligrams per kilogram, the percentage of occupancy of the target is similar to 10 milligrams, and they have chosen this dose. You can see at lower dose, the percentage is as much, and we can say it's really similar. So it's possible to be treated with a lower dose of nivolumab, probably, and to save some money. Okay, it's almost done. We have just 15 minutes left to consider the 5 compounds, the 5 groups, ADC, which are monoclonal antibodies. You remember these drugs, monoclonal antibody, but with some cytotoxic conjugating zinc linker between cytotoxic and monoclonal antibody. So, what are the ADC we are using in oncology, or which are developed by the pharmaceutical company? It's a monoclonal antibody corresponding to a protein not necessarily involved in the oncogenic phenomena. We just need a protein overexpressed in tumor cells in comparison with the normal tissue. So the monoclonal antibody is going to bind this target and then to be internalized. And in the lysosomes of this tumor cell, the cytotoxic is going to be freed and to kill the cells, and also with a bystander effect to kill other tumor cells around these tumor cells. The bystander effect is essential for an ADC to be enough effective. How to perform the phase 1 of ADC? Maybe you remember it was one of my first slides. For cytotoxic, we were very cautious. We increased less and less. It's what we call the Fibonacci method of increased dose. For monoclonal antibody, we don't respect this Fibonacci schema. You have here usually what are the level of dose for a phase 1 of a monoclonal antibody. I specify a regular monoclonal antibody, the monoclonal antibody we have considered just before. So you see the level of dose. We can do that because the adverse effects are not dependent of the dose. But for ADC, you have here the example of several ADC. You have the level of dose applied. And what is applied? We apply again the Fibonacci schema, which was not used anymore for targeted therapy and checkpoint inhibitor, but again, we use this cautious way to increase the dose for ADC. And you have here the result confirming it's important to be careful during the phase 1. You see for this ADC, you see the level of dose, and here the number of patients with the dose-limiting toxicity. No toxicity at this level of dose, especially at 2.1, and then at the level 2.8, which is not very different than 2.1, you can see a large number of patients with the dose-limiting toxicity. So it was necessary to have an increase of dose very cautious for this compound. A similar result for another ADC. An ADC used for the treatment of breast cancer, and breast cancer with another expression of HER2. The monoclonal antibody is trastuzumab, which is a drug itself, but here it's an ADC with deruxtecan, which is a cytotoxic bound to trastuzumab. And you can see here, it's a way to represent the efficacy in oncology. We measure the change of size of the tumor. So what we expect is a decrease of the size of the tumor, like for these patients. We don't expect, like for this patient, an increase of the tumor, but what is shown here, it's the efficacy in some patients, and you can see the efficacy is observed particularly for the high level of dose, more than for the small level of dose in white, for example. Here, you have also the change of the tumor depending of the dose. You can see there are more efficacy here than for the small level of dose. And also for ADC, which is also important, is the level of expression of the target. The woman with the high expression of the target, HER2, for this ADC, have a larger, higher efficacy than for patients with a low expression of the target, which is something expected. What about the relationship between pharmacokinetic and efficacy? Here, it's for another ADC, you have the probability of response, of efficacy, depending of average concentration. Average concentration is what you can call AUC. It's the AUC. And you can see there is a relationship. There are two curves because there are some patients who treated and some other naive for treatment that I'm not going to comment in detail. Here, it's the relationship between, again, the AUC and this time the probability of veno-occlusive syndrome, which is the main side effect, which could be very severe and could be lethal for the patients. And you can see the probability of this side effect increase with this AUC. Just to show you an example of PK-PD relationship for ADC. I think it's over since it's a conclusion, but we have some minutes left. What do you think? about this relationship between pharmacokinetic and pharmacodynamic of ADC. Do you think it's like small molecules? It's something with a causality between the two parameters. Pharmacokinetic has an impact on efficacy. Or do you think it's like monoclonal antibodies? There is a relationship, but with no causality, because there could be a confounding factor like the performance status, the albuminemia of the patients that explains this relationship. You understand the development of my presentation about PKPD to show you it's different between the three groups of anti-cancer drugs. And we finish with this newest group of anti-cancer drugs with some observation for this one. It's not too old, it's 3 years old publication. And I ask you your opinion after my 1 hour and 45 minutes dedicated to monoclonal antibody and small molecules. What I've done. We have lost maybe the person. I'm looking for your colleague to see if it's still connected. No, it's not anymore connected. In India, maybe it's okay. It's gone, but you are still here. And you couldn't leave now. You have still 5 minutes to stay. Do you have an opinion? Before answering, you see the impact of the opinion, of the answer. I told you for small molecules pharmacokinetics, it's an issue. It's not the only one and maybe not the main issue, but it's an issue. We have to consider the pharmacokinetic to adjust the dose, etc., etc. For monoclonal antibodies, I told you, it's not an issue. Considering the dose we use, we don't have to look at pharmacokinetics. So the question is here, for ADC, is it necessary to individualize the dose to avoid too higher concentration in some patients? Is it necessary to consider to increase the dose for patients with a lower exposure? These ADC are very effective. It's like chemotherapy, except they are a little bit more bright than chemotherapy, since they are a kind of vectorizations onto the monoclonal antibody. No, you don't make any comment or please tell something, because I don't have the answer anyway. There are new drugs. Of course, they have been studied by the pharmaceutical company. We have some results, and maybe it's why I have an idea, I have a proposal to make you myself, but I'm more interested by your opinion than by mine. I know already. No? So the question is, are there these ADC more like cytotoxic, and they are composed of cytotoxic in some way?
Oh, because
Or they are more linked to monoclonal antibody, and they are composed of monoclonal antibody?
they are not more like cytotoxic because somehow they are specific, because also they contain this linker, like the cytotoxic one, but it will be only activated in a specific place, like in the lysosomes. So it's somehow dependent on the pH, on the acidic pH. So it's not the same as cytotoxic drugs because there are non-specific area or lots of specificity. And at the same time, it's not really like the idea of the macromolecules of the monoclonal antibodies, because with monoclonal antibodies, like they do not really enter the cell, like inside.
So your feeling is they are more like monoclonal antibodies, so maybe it's not, this relationship is not direct.
Yes.
It's a way to think, and maybe you are right, but it's the opportunity, your answer is the opportunity for me to remind you, all of you, they are not internalized only in the target cells, only the cells that express the target. Like monoclonal antibody, in the endothelial system, they are also hydrolyzed. And there are some, what the cytotoxic he calls the payload. The payload is a specific name, the special name to the cytotoxic bond to the monoclonal antibody. The payload is going to be in the plasma after metabolization of this ADC in the endothelial system. Okay, so there are some concentration of payload of cytotoxic low, but according to a continuous way, because the drug is going to free some payload continuously. So, okay, there are monoclonal antibodies, but they are also like cytotoxic. And myself, I think for this compound, and also by considering this kind of relationship, we see a small difference of dose has a profound impact on the toxicity. We can imagine the variability, the pharmacokinetic we have at the recommended dose is going to have an impact. And some additional information that suggests that pharmacokinetic is a key issue. This ADC, for the monoclonal antibody, we stop to give by kilogram. Since the dose is not an issue, now for nivolumab, for cetuximab, we are used to give the same dose to every adult. But for ADC, the doses are given per kilogram. Since there is a correlation between the pharmacokinetic and the weight, it's important to consider the weight of the patients. And we observed after several months and sometimes several years of using this ADC, the obese patients who have a high weight, so they get some high dose. We observe higher toxicity and sometimes not acceptable toxicity in obese patients with ADC, which is also a sign that the pharmacokinetic is an issue. And probably we have to consider not only the weight, but to consider the ideal weight of the patient rather than the actual weight to give the dose. So just to give you, and it will be my conclusion of my presentation today, for ADC, maybe the story would be more like cytotoxic than for monoclonal antibodies. But there are still new drugs, and we will see that thanks to additional study. Okay? So in terms of at least of time, the schedule is respected. It's 5 p.m. The talk is over, but of course, if you have some lessons, I'm here to answer.
Is it a good way to check efficacy of a drug by just looking at the reduction in the tumor size? And these plots only show reduction in tumor size, but we don't see the after. We don't know the afterward. We only see it in survival.
It's important. Progression-free survival. Could you imagine? I don't wish you will be like that, but we could imagine ourselves. We are patients with a metastatic disease. To have a drug stopping the progression is better than not to stop the progression. It's something very important. To look at the side, I'm looking for here. Here, they don't look at the progression, they look at the change of size of the tumor. It's also an important parameter. It's better to have the size decreasing than not decreasing. But imagine the motivation of your question. You think it's not enough. We have to look to something more accurate, more precise. Maybe not for the specific patents. For the specific patents, the most important information are there. But to better understand the drug and to better use the drug, of course, it's important the ideal is to get the cells of the tumor and to look at the cells and to understand why the drug is not anymore efficient, to look at the resistant phenomenon when it's possible. In clinics, it's good to be able to make a biopsy to understand the things. So it's not enough, but in clinics, the thing is more important for the patients. And it's also important to evaluate the drugs. What is the answer of your question? You think about
No,
something?
I don't have an answer. I just
No, but you could have something in mind as a motivation of your question.
there are some remaining stem blood cancer cells inside the tissue, and they are not eliminated by the drug. We see only elimination of other cancer cells.
Yes. Look at the side of the tumor doesn't consider the cells which could be involved in resistant phenomena. And also, I'm going to take your question when I will give you the next presentation talking about clinical trials. And I will comment the limitation of this endpoint. Okay. No more question? It's okay? Okay, thank you. I hope it has been useful at least for some way for you. Some more applied lesson maybe than the lesson you are already